This is part 2 of blood vessels. So we've looked at veins and we've looked at capillaries, and now we're going to look at arteries. So arteries are vessels that are closer to the pumping of the heart than veins or capillaries. And so as a result, they must be able to withstand very high blood pressures. So they have much more smooth muscle in their walls, and this smooth muscle allows them to expand and then contract as blood pressure changes every time the ventricles contract. So if you remember in class, if you find your carotid pulse, so just go to either side of your trachea and walk your fingers up just underneath your jaw, you should be able to feel your carotid pulse. And that what you're feeling is blood moving through your carotid artery every single time your ventricles contract. So each time the ventricles contract, blood pressure goes up and we feel that pulse. And then when the ventricles relax and fill up again, then we don't feel anything beneath our fingers. So this is this continuous pulse of high pressure, and every time that occurs, the arteries, because they're very elastic, they expand a little bit and then they recoil and resume their original structure or original position again. And this helps prevent huge swings in blood pressure in our system. So if we take a look at this picture, the top vessel we see here, that is an artery, very nice and round with a big thick wall, lots of smooth muscle. The vessel that we see below, this is a vein, a much larger lumen with not very much smooth muscle in the wall. Again, if we take a look at this picture, this is another cross-section looked under a microscope. The bottom vessel here, that is an artery. And again, you can see all of this pink connective, or this pink muscle, smooth muscle tissue. And then the top vessel that we see here, that is a vein. And again, not as kept as round, and it's partly because structurally it has less smooth muscle. So as we'd said, every time the left ventricle contracts, there's a pressure wave that goes through all of the arteries. The closer to the heart that we feel that particular wave, the higher the pressure will be. And so that's why our carotid pulse, which is right here found in our neck, that's why that's our strongest pulse. It's because it's the closest one to the ventricles contracting of anywhere else in the body. But we can still feel that pressure wave even further from the body. So for example, we could feel it in our brachial artery, which is the one in our arm, or a radial artery, which is the one in our wrist, or our femoral artery, which is in the groin, or so on, or pedal in the foot, or tibial in the leg. So if we count the number of pulses that we feel underneath our fingers per minute, then that is equivalent to each time that the ventricles contract. So that gives us our heart rate. So when we talk about blood pressure, that is the pressure of the blood as it pushes against the inner walls of blood vessels. And of course, pressure is going to be highest where it is closest to the contraction of the ventricles. And so that is in that huge artery that's leaving the left side of the heart, which is in the aorta. And so in the aorta, if we were measuring blood pressure, first of all, it would be the highest in the body, but also we'd see the biggest swing. So we would see pressure go up when the ventricles contract, and then we would see it drop as the ventricles fill up. And so that's why we see this. Swing. So when the ventricles contract, that's called systole. That's the part of the cardiac cycle, and so that's why we call that high measurement of pressure systolic pressure. So that's the pressure in the arteries during systole. When the ventricles are relaxed and are filling up, then pressure drops in the arteries, and the lowest pressure that it reaches is what we call diastolic pressure. So pressure in the arteries during diastole, or when the ventricles are relaxed. When we talk about measuring a person's blood pressure, we talk about clinical blood pressure, because technically if we were to say okay, so what is a person's blood pressure? If you were a smart aleck, you could say, well, in what blood vessel? Because, of course, the pressure is going to be highest in the aorta, and then it's going to start to drop as we move through the smaller and smaller arteries, and then in the capillaries, and then when we get to the veins, in fact, in the large veins, pressure may actually be negative. So when we talk about clinical blood pressure, it's blood pressure in the large arteries as close to the heart as we can measure. So it's very difficult to measure the pressure in some arteries, including our aorta. We can't get a blood pressure cuff around our aorta, nor can we put a blood pressure cuff around our neck. So when we talk about clinical blood pressure, we're really talking about blood pressure in the brachial artery, which is this one in our arm. So that's as close as we can get to the contraction of the heart, and do that non-invasively. So normal blood pressure really depends on a person's age. The younger a person is, the more elastic their arteries are, and so therefore the lower the blood pressure will be. As a person starts to get older, their arteries start to get stiffer, and as a result, their blood pressure goes up. So technically, normal blood pressure on average should be around 120/80 if you're under the age of 40. Now women tend to have a much lower blood pressure than that. So women tend to be more around 105 or 110 over, let's say, 65, 70, 75. If you're over age 65, then your average normal blood pressure would be about 140/90. So what factors affect our blood pressure on any given moment in the day? When our arteries are constricted, meaning they're narrower, that's going to increase blood pressure. So, and we've talked about it before, if we activate our sympathetic nervous system, so if we're very frightened or angry, then that's going to constrict our arteries, and that will increase our blood pressure. We also can increase blood pressure with certain chemicals. So for example, nicotine increases blood pressure, as does adrenaline or epinephrine. On the other hand, we can lower blood pressure by making our arteries wider, so having them dilate, and we do that by decreasing activity in the sympathetic nervous system, or by certain chemicals such as histamine or alcohol. We can also increase blood pressure by changing the volume of blood. And so if we increase the amount of blood in our arteries, then that's going to increase blood pressure. So for example, if our kidneys absorb more water. The flip side of that is that if we decrease blood volume, that's going to drop blood pressure. So for example, if we excrete more water, or if we lose a lot of blood, that's going to decrease our blood volume and then drop our blood pressure. The third factor is that if we increase our heart rate, or increase how hard our heart contracts, our force of contraction, then that's going to increase our blood pressure. And if we decrease heart rate or decrease our force of contraction, that will lower blood pressure. So it's important to understand, especially when we do our pharmacology cardiovascular drugs, it's important to understand these different factors that will affect blood pressure. When we talk about a prolonged elevation of blood pressure, so for somebody whose blood pressure never goes below 140/90, then we can talk about hypertension. So clinically, if somebody's systolic pressure is consistently more than 140 and their diastolic pressure is consistently more than 90 millimeters of mercury, then we would say that they have hypertension. Now, hypertension isn't something that happens overnight. It happens very gradually, and so people are not really aware that their blood pressure is gradually creeping up. And there are very few symptoms until we get to a point where the damage and structural changes have occurred and they can't be reversed. So once structural changes have happened in the blood vessels, and they are irreversible, then a person will get symptoms such as headaches or heart palpitations, where sort of irregular heartbeats, dizziness, and lightheadedness. The reason that hypertension is such a problem is that when blood pressure is very high, it damages blood vessels. And when we damage blood vessels, it causes a condition called atherosclerosis or arteriosclerosis. And we're going to talk about that in a minute. And atherosclerosis causes further increases in blood pressure. So it gets into this cycle where hypertension is causing damage, and the damage is causing higher blood pressure. With higher blood pressure, the heart has to pump a lot harder because it's pumping against a high resistance, and that can cause a heart attack or heart failure. It can cause kidney failure, it can cause stroke, and it can lead to damaged blood vessels in a lot of tissues, including things like the retina of the eye, causing a lack of vision. So the main causes of hypertension are blood vessel damage, atherosclerosis, and that's related to some genetics, sometimes hormone imbalances, but mainly related to many lifestyle factors. So things like smoking, things like a poor diet, especially diets high in refined carbohydrates and salt, obesity, stress, and a lack of physical activity. Again, once the structural changes have occurred, we can't reverse that anymore. We can't permanently lower blood pressure. So the best we can do then would be to treat it by artificially lowering blood pressure using drugs. However, the best treatment obviously is to try to prevent the structural changes from happening in the first place. And because it's so heavily related to lifestyle factors, then having this healthy lifestyle early on before those changes have occurred is really key. The other thing is that because the symptoms occur gradually, it's important to have a person's blood pressure checked regularly so that we know, is something happening, and should we alter lifestyle before we have to actually use drugs. So we mentioned there's a condition that is caused by any type of damage to blood vessels, and it's called atherosclerosis. And what occurs is that that when there is damage to a blood vessel, it causes a series of reactions in which plaque gets built up inside the wall of the artery. Now, this isn't something that you can kind of go in and scrape off. This actually occurs right within the muscle of the artery, right in the wall. And as this plaque builds up, then it causes changes in the wall. The wall becomes thicker, the lumen or the interior of the artery becomes narrower, and it makes it very highly risky for things to come along and maybe entirely block that artery. For example, a blood clot, or sometimes plaque or bits of the wall can break off and then clog that particular artery. The other thing is it makes the arteries really, really stiff, and as we know is that if the artery becomes very rigid, then that increases blood pressure as well. These plaques, there's been quite a lot of research that have been done on that plaque and what causes the plaque to form. The plaque is made up of fat, cholesterol, and calcium. And we have a type of cholesterol in our blood called low-density lipoproteins, or LDLs. And they carry cholesterol, and they bring it over to the blood vessel and deposit it. And this causes the artery to become inflamed. We also have another type of cholesterol called HDL, high-density lipoprotein. I like to think of HDL as the happy cholesterol, and it actually removes cholesterol from the tissues and takes it back to the liver. So ideally, we want low levels of LDLs in our blood and high levels of HDLs in our blood, and that is a good predictor of whether or not this process will start to occur. So here's an animation showing an artery that has atherosclerosis. So this is this plaque buildup inside the artery, and as you can see, blood flows along, but then there may be something like a blood clot or a piece of plaque that has broken off and then totally occludes the artery. If this blows through and blood flow is restored, then there's no problem to the tissue. The problem is that as this gets narrower and narrower, we get to a point where maybe this does not release and blood flow is permanently blocked. And if that occurs in the heart, that will cause a myocardial infarction or a heart attack. And if that occurs in the brain, then that would cause a stroke. Here are some pictures of the inside of walls of arteries, just to show you what the plaque looks like. So this is atherosclerosis. We can see this plaque inside this artery, and here's a blood clot that has blocked this artery. The blood clot could come from someplace else, or sometimes the damaged walls of the vessel itself form their own blood clots right in that particular spot. In the middle picture, you can see here's another interior part of an artery, and you can see this plaque right here. And here again, over here, you can see this artery has virtually been destroyed by plaque. This is a really good picture that shows the plaque buildup inside an artery, because it shows that it's not just something that's kind of flaked, that you could flake off from the inside. It's actually part of the wall of the artery itself. So lots of things will contribute to this process. As we said, anything that damages the walls of the arteries, the inside walls of the arteries, will trigger this process. So that includes a lot of pressure on the inside of the walls, so high blood pressure. Nicotine will damage the interior walls of the arteries. High blood sugar, so high glucose levels, will damage the inside of the walls. Diets that are high in trans fat or salt, and lack of exercise, obesity, heredity, those are all factors as well. And again, we can predict whether this process will occur by measuring our levels of LDL and HDL cholesterol, and particularly we want to have low amounts of LDL cholesterol and low amounts of triglycerides in our blood to try to prevent this from occurring. So how do we treat this? Again, because once the structural changes have occurred, we can't reverse them. So if we detect it early, then a change in diet and lifestyle to lower blood pressure and lower certain types of cholesterol, lower our LDL cholesterols. There are drugs that we can take that try to prevent blood clots if we have very narrowed blood vessels. There are also some drugs that we'll talk about that will lower our blood cholesterol levels, our LDLs and triglycerides, and presumably also raise our HDL cholesterols, our happy cholesterol, which may help slow down this process. We can't reverse this, so once this has occurred to the walls of the arteries, there is no way to reverse and change that structure, go back to healthy vessels. One thing we can do is try to open up vessels using a technique called angioplasty. And what they do is they insert a catheter inside a blood vessel. So this is the area that has plaque that's very narrow. And there's a balloon on this little catheter, and once they get it into the spot, then they inflate the balloon and it squishes the plaque and opens up the blood vessel. Here's another couple pictures of this. So this is the actual catheter, and this is what the balloon looks like once it's inflated. So here we've got, this is an angiogram, and we can see the catheter being threaded through the blood vessel. There's the area of narrowed blood vessel, and this is after they have inflated the balloon and they've opened up the blood vessel. Now the problem is that when they do this, they open up the blood vessel, but then of course the whole process starts again and the blood vessel will narrow in that same spot again. So what they discovered is that to keep the blood vessel open, they can put in a stent, and this is a little mesh tube that they can actually insert in the blood vessel to keep it open. They also have discovered that sometimes they get blood clots or plaque that starts to build up around the mesh. So they've now got stents that they dip in certain drugs, they coat it in drugs, and that prevents blood clots and plaque from sticking to the mesh, and that helps keep that artery open. So here's another angiogram. We can see two spots where there are narrowed blood vessels. These are coronary arteries, so arteries in the heart. And here we see after they've done balloon angioplasty and inserted a stent, and we can see that they're no longer those narrow areas, and that blood flow has been improved in both of those spots. Now there's only so many stents that you can put in a blood vessel, so usually 3 or 4 maximum could you put along a particular blood vessel. So if there is an artery that has many areas of occlusion, or if the occlusion is very, very long and they can't put the stents end to end to end, then they may have to just simply bypass that. So they need to just reroute the blood around those areas that are blocked or are narrowed. And this is called bypass surgery. And if it's done in the heart, we call it coronary bypass surgery. So what they do is they take an artery or a vein from an arm or leg, and then they run it around the area of the occlusion. So here, this is the coronary artery that's blocked. And here they've run this right off of the aorta and then down to below where the narrowed area is. And so that allows blood flow to resume to this part of the heart. Here's an actual picture of coronary bypass surgery. If they just put one graft in, it's called coronary bypass surgery. If they put 2 grafts in to go by 2 areas of narrowed arteries, they call it double bypass or triple bypass or quadruple bypass surgery. So this is the heart, and these are the grafts right here and right here. So there's 2 of them that have been put in this case. The very last thing I want to just talk about is that when we're measuring blood pressure, that this is how it's done in a traditional sense. Again, blood pressure, clinical blood pressure, we take using the brachial artery. So that's what we're actually measuring, is the pressure inside the brachial artery. So what we do is we put in a cuff just around the arm. We can read the pressure in the brachial artery just below the cuff, and then we put air inside the cuff. We inflate it, and we can measure the pressure inside the cuff. So we inflate the cuff, and we inflate it until we totally block blood flow through the brachial artery. So if we totally block blood flow, we don't hear anything, any movement of any blood through the artery. If we just listened without the cuff inflated at all, we wouldn't hear anything either, because blood flow is very smooth through that artery. Okay, so we put in air inside the cuff, we inflate the cuff to totally block blood flow, and then we gradually let this cuff deflate, and we listen for blood to flow through. Now when blood flows through in a turbulent way, we can hear that. And so when blood just first starts to squirt through that artery, underneath the cuff, we can hear that. We can hear that psh, 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 as it's kind of squirting through. So we know that when we first start to hear it come through, that is the highest pressure in the artery, and that's our systolic reading. And then we listen, we can still hear it, psh, 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 psh. And then once we no longer have turbulent flow and the cuff is deflated to a point where we don't hear anything, we lose the sound, then that is our diastolic reading. So if we take a look at this animation, here we've pumped up the cuff. At this point there's no blood flow. We decrease the pressure in the cuff until we hear our first sound, and then we decrease the pressure in the cuff until we lose sound altogether. When we hear our first sound, that is called our systolic pressure, and when that sound goes away, the moment that we hear the last sound, that is our diastolic reading. Now we have machines, even portable machines that people can use in their homes in order to measure blood pressure, and we will do that when we're in class. We'll take a look at using those machines to measure blood pressure. That is all for now, and this is the end of this section.